let's have a look at some muscular lesions. Most likely the more popular lesion in this area is going to be a problem with the adductor muscle. And then we're going to differentiate two localizations. There could be a lesion at the tenoperiosteal site, or there is a lesion at the musculotendinous junction. So what do we find in the examination? Resisted adduction is painful, but we also need a positive palpation, a painful palpation. If the palpation of the adductor is not positive, then we suspect a pubis problem, a fracture or a periostitis. The lesion at the musculotendinous junction reacts very good on friction massage. The tenoperiosteal localization, also friction massage is indicated, but in acute cases we can also start with infiltration. And of course the palpation of the tenoperiosteal site is totally different than the one at the musculotendinous junction. Again, I refer to the films on the practical execution of all techniques, where I show you in detail how you can palpate those structures. A psoas lesion is also an option, and in that case the resisted hip flexion will be positive. And we are lucky because mostly the lesion lies in the lower muscle belly, which is just below the inguinal ligament and medial to the sartorius. And how can we find that? Well, we ask the patient to adopt the Faber position, a combination of flexion, abduction and lateral rotation, and in this way you can visualize and you clearly can palpate the sartorius. Well, the part of psoas we need just lies medial to the sartorius and under the inguinal ligament. So in that little green zone you see on the slide. Lateral from the sartorius we also have the rectus femoris, and I come back to that a little bit later on. When we palpate and friction the psoas, make sure you don't flex your fingertips too much. We always do that with flat positioned fingers, otherwise it could be too sensitive for the patient. If you palpate too far medially, then of course you come in the neighborhood of the arteria, vena and nervus femoralis, and it is not the purpose that you friction over there. A rectus lesion, well, you're also going to have resisted hip flexion, which is painful, but also the resisted knee extension. And as I just mentioned, you find the rectus lateral from the sartorius, so you ask the patient to adopt the Faber position again, and then you really hook with your fingers over the rectus. So we really have a sharp and a deep contact, but then you can feel the rectus very clearly. A sartorius lesion is very, very rare. Yeah. It's more likely you have a fracture of the spina iliaca anterior superior. And in that case, the resisted flexion plus lateral rotation is not only painful, but also weak. And you remember from the basic lectures on clinical reasoning that the combination of pain and weakness mostly points in the direction of a more severe lesion. So mostly we talk about an avulsion fractures seen in young athletes, and they describe sudden pain on activity, running becomes impossible, walking is painful, they are limping. And in the examination, as I told you, the resisted flexion and lateral rotation is painful and weak. Perhaps the resisted knee flexion is also painful. Of course, medical imaging is positive, palpation is positive, and we just need a little bit of patience. There is a mechanism of spontaneous cure. When the resisted hip flexion is positive, then there are different differential diagnostic options. We just talked about the rectus, we talked about the sartorius, but in the case of a fracture of the trochanter minor, well, your hip flexion will be painful plus weakness. If there are metastases, then mostly we find an explosive image. Too many tests are positive, passive test, resisted test, the image is too big. Or the patient has perhaps a visceral hernia, or he has a tumor, or he has a nerve root problem L2, L3. L2 weakness is more psoas, L3 weakness is more quadriceps. And as I described you in the lecture on hip examination, if the resisted hip flexion there's no force, then mostly that goes together with some kind of psychogenic disorder. But keep those options in mind. A gluteus lesion, well, is often found on medical imaging. Very often. But a real symptomatic gluteus lesion is in fact very rare. We find a positive resisted abduction, positive resisted extension, but in that case bursitis is much more likely, and of course in this area there are plenty of bursa, so this is an option we really can't underestimate, but I refer to the specific lecture on bursitis. An iliotibial tract lesion is also frequent. Mostly the lesion lies cranial from the greater trochanter and reacts well on friction massage. But the clinical image could be more or less the similar as the one of a gluteal or a bursitis trochanterica, and sometimes it's difficult to differentiate. What we can do is ask that the patient is standing, he crosses his legs and does a side flexion. And if that produces more pain, then perhaps our first idea is a iliotibial tract lesion. It's not a certainty. What else can we do? We can give a diagnostic friction massage. We just palpate a specific spot with friction, and after 5 minutes we retest again. If it would be a bursitis, nothing would have changed. If it is an iliotibial tract lesion, then most likely the functional test after the diagnostic friction massage will be better. And then finally, we could also have a quadriceps or a hamstring lesion. Well, if you have an acute hamstring muscle belly lesion, of course you're going to have muscle spasm. Muscle spasm is going to result in a limitation of passive movement, so in other words, a straight leg raise movement will be painful and limited. In case of a tendinopathy, there is never limitation of passive movement, and this is a general rule all over the body. Tendinosis never causes limitation of passive movement. So if there is limitation, then there's another reason for that. Okay? And of course we can friction the origin of the hamstrings. This is a rather rare lesion, or we friction the muscle belly.